This is one of the two endowed lectureships for the Division of Endocrinology and Metabolism, and I'm going to be introducing Dr. Mark Molitch, a colleague and friend of mine for a number of years. I want to show you a picture of Dr. Ed Leonard, just to remind you that there was John Leonard. Ed Leonard was the chief resident here. So John Leonard was, I want to remind you that there was a time when sideburns were fashionable, but as I was thinking about Dr. Leonard and coming to work today, the question is, when we show these black and white photos of faculty from years ago, what's the relevance to residents, fellows, students, junior faculty who've never heard of this particular person? And there's huge relevance. I want you to think back to high school, college, medical school, any other graduate school experiences you've had, childhood, and think about the people who touched your lives and endowed you with some enthusiasm and interest in the sorts of things you're doing today. Think about the Mr. Chips of your experience. And Dr. Leonard, John Leonard, was that man for many of the house staff here at the University of Washington. He was the very first winner of the Beeson Award, which the residents give to the most outstanding teacher and the person that they think is emblematic of really the finest attributes of academic medicine. He was the chief of medicine at the building which used to be the Pacific Medical Center, then was Amazon, is now continuing the beautiful building overlooking the Sound and I-5 up in Beacon Hill. And he was renowned for his physical exam skills. He diagnosed hemochromatosis from across the room in a patient that people were puzzling over. He had a great deal of joy in seeing patients and teaching the residents and the students. He took his first vacation with his family at age 42 and went to Hawaii and died of an acute myocardial infarction while on vacation. So this award recognizes his contributions, but I want you to pause. Many of you didn't know Dr. Leonard, but think about the people who contributed to your lives in this sort of a meaningful fashion. Dr. Molitch has contributed in that way both locally at the Northwestern University in Chicago, nationally and internationally. He's given lectures around the world. He's the sort of guy who's got a quirky, maverick perspective on things and is constantly questioning dogma and either trying to prove it right or he takes much greater delight in proving it wrong. He's the only person I can think of in the world that when we ask the question, who can we invite to give a diabetes lecture and a pituitary lecture, that could do both and have a history, a track record of credible research in both areas. I asked him last night, he's most renowned in my mind as a pituitary expert. In fact, last year was given the Clinical Educator Award by the Endocrine Society primarily for his contributions in pituitary disease. And I asked him, well, why have you spent so many years doing diabetes research, and why are you equally renowned in diabetes? And he looked at me and said, well, that's where the money is. So he's also quite practical. In 1997, he was selected by the ADA as their Educator of the Year. So he's won both of the major teaching awards in the ADA and the Endocrine Societies. Today he's going to be talking about pituitary disease and a practical approach to this. But before I give him the podium, I want to acknowledge one other area of his life. He and his wife, who's a transplant nephrologist, decided they wanted to give back to the underserved. And many, many years ago, long before it was the cool thing to do and before people were really thinking about global health, they established a clinic in Bolivia. It's a free clinic, and it serves about 40,000 people. He and his wife go down there 3 or 4 times a year, and they have a full-time staff that they pay for out of pocket throughout the year to care for this community. So this is somebody who was doing global health long before it was vogue. So please welcome Dr. Mark Molitch. All right, now he's going to disclose his finances.
Well, so thank you very much, Brian, for that very nice introduction. Let's see if we can, let's see, F5, right. There we go. Well, I feel very honored to be giving the Leonard lecture, and looking at that picture reminded me of what I looked like back then as well, except when I was doing my fellowship, I actually had hair down to my shoulders. and we were even longer sideburns, et cetera, at that time. So things have moved along. Let's see here. So again, my disclosures. And so my idea this morning is to give a general talk about pituitary tumors, and we're going to be showing MRI scans and things like this. So what I thought I should do first is sort of refresh your memories about what a normal pituitary gland looks like on MRI. And so this is the pituitary shown here. This is the hypothalamic pituitary stalk coming down to serve the pituitary and transmit the release and inhibitory factors. On either side is the cavernous sinus, and within that is the internal carotid, and those show up as a flow void, as you see here. And then up above this is the optic chiasm, so that you can see that in the normal person, there's a considerable amount of room between the pituitary here and the optic chiasm. So visual field abnormalities that occur with pituitary tumors really imply that there's a pretty good sized tumor. This is the sagittal view, again showing the same structures with the optic chiasm, stalk, and pituitary here. And so where this arrow is pretty much the direction that the neurosurgeon takes in going transsphenoidally down here up to the pituitary to try to remove the pituitary tumor. So we talk about tumors of different sizes. The microadenoma, something that's less than a centimeter in size, and this would show up as a hypodense area. We also have macroadenomas, tumors greater than a centimeter, and here you can see on the coronal and the sagittal views this large tumor invading the cavernous sinus, partially surrounding the internal carotid, and also sort of there's a deviation of the pituitary stalk. But again, it's a little bit of distance away from the optic chiasm, so there wouldn't be any need to do visual field testing in a patient like this. On the other hand, in this patient, you would do visual field testing with this very large pituitary adenoma, so we can have all sizes of these things. So when we see a patient, we're particularly evaluating a patient who has a potential pituitary tumor, we like to know whether that tumor is making hormones and making them to excess. So you can have the Cushing's disease that we'll talk about, or acromegaly, hyperprolactinemia, but there may be other causes of hormone excess in a patient like that. So if you have a patient who might be taking medications such as a phenothiazine that might cause hyperprolactinemia, you'd have to sort of exclude that when you're evaluating the patient. And then if you do have an elevated level, we usually use the principle within endocrinology of trying to show that you can suppress the excessive level with normal type of suppressive medications such as the dexamethasone suppression test for Cushing's disease. And then we also, if you're evaluating for hypopituitarism, and you do that when you have large mass lesions, then you need to do a stimulation test to see if you can stimulate a normal level in a patient. Imaging is with MR if possible, CT if you don't have MR available to you. And again, visual field testing is only done when the optic chiasm is impinged. So we can divide our effects of these tumors into these hormone effects that we just talked about, and then mass effects from these large tumors. And so patients may present because of those hormone oversecretion or these mass effects, such as headache, visual field disturbances, cranial nerve palsies from invasion of the cavernous sinus laterally, hypopituitarism from the large lesion. Diabetes insipidus is actually pretty uncommon from a pituitary adenoma. And so if that was occurring in a patient with a large mass lesion, we would think about a lesion that originates in the hypothalamus, such as a craniopharyngioma. Very rarely you can have these huge tumors that cause other hypothalamic dysregulation, causing problems with temperature or food intake. So in general, our goal of therapy is to cure the patient. So we want to get a hormonal cure. We would like to get rid of the tumor mass when possible. If there is a visual field defect, we'd like to correct that. We would like this treatment to be definitive and prevent the recurrence of the abnormalities. And we'd also like to do no harm, to preserve what pituitary function might be there, and maybe even improve hormonal deficits should they be there. And then finally, to correct the systemic sequelae. So in the patients with Cushing's and acromegaly, where there are many systemic sequelae, we'd like those to be improved as well. So we've got a number of therapeutic modalities that we can use. We have surgery, and so the surgery is predominantly a transsphenoidal approach. There can be an incision over the gum, or you can do an endoscopic approach through the nose. Craniotomies are reserved for very large, extensive tumors, and we really need to do those for pituitary adenomas. Irradiation can be done. There's conventional and stereotactic radiation. And then finally, we have a number of medical therapies for the specific tumor types that we'll talk about more. So this is transsphenoidal surgery as done at Northwestern. And this may explain why our surgical results may not be as good as some other centers, and hopefully you have better results here. But there can be complications that can arise from transsphenoidal surgery. This is a survey done a few years ago that looked at the complications of transsphenoidal surgery for all pituitary adenomas, and it's divided about by the number of operations that the neurosurgeon had done. So somebody who had done less than 200, 200 to 500, or over 500 operations. And you can see that all of these complication rates go down with increasing experience of the neurosurgeon. On the other hand, you can still have a very experienced neurosurgeon having bad outcomes too. Just experience itself doesn't mean that much, but you need a lot of expertise in this area. And so you need to always refer your patient to an experienced and successful neurosurgeon. So this is the endoscopic approach where everything is done through the nose using the operating endoscope, and this would be the instrument used to remove this pituitary adenoma. And this is generally the preferred technique by the neurosurgeons in doing transsphenoidal surgery. In general, it shortens the operating time, although the cure rates, the success rates, are really no different from the conventional approach. Radiotherapy, again, conventional radiotherapy has been done for years and years. We now have the stereotactic types of radiotherapy. They can be the gamma knife, linear accelerator, where you have a number of different beams that then get focused down on the pituitary gland. Sometimes this is referred to as radiosurgery, but that's clearly a nonsensical term since there's no surgery involved at all, and it's sort of involved, the term is evolved to keep the neurosurgeon's hand into the radiotherapy and perhaps the reimbursement as well. So when would we actually use radiotherapy? It's kind of a tertiary mode of treatment. So if you have a patient who's got a prolactin-secreting tumor, where you have continued growth of the tumor despite medical therapy and surgery, if you have growth hormone, ACTH, and TSH-secreting tumors, you again would use this if you have persistent hormonal excess, again perhaps with a rising size of the tumor. We often will use radiotherapy in conjunction with medical therapy because it takes a long time for radiotherapy to work. And then finally, in a patient who's got a non-functioning tumor, if there's persistent tumor or tumor regrowth following that surgery. Part of the reason why we reserve it as a tertiary modality is because there are adverse effects of radiotherapy. And these are the ones for conventional radiotherapy. And hypopituitarism we expect to occur in about 80% of patients. And this is because all of those radiation beams are really focused down on the pituitary and hypothalamus so that there's damage to the normal structures there as well as the tumor. We now know that with the stereotactic radiotherapy, the gamma knife and linear accelerator, this rate of development is pretty similar to conventional radiotherapy, although we don't have the long 20-year experience, but you can pretty much superimpose those early years one on top of the other. Now, second, brain tumors occur with conventional radiotherapy in a few percent of patients. Strokes are increased. Cephalomalacia and cognitive dysfunction now is very rare with conventional doses of radiotherapy. And we're hoping that these other complications of radiotherapy don't occur with the stereotactic radiotherapy, but we really don't have the long-term experience to prove that. But hopefully, because the amount of brain irradiation will be less. So let's now turn and look at some of the individual hormonal syndromes. And so with hyperprolactinemia, these are the usual symptoms that patients will present with. Women present with amenorrhea and galactorrhea. Men will present with symptoms of reproductive dysfunction, impotence, and infertility, but they also will generally present with some of the mass effects because men tend to present with larger tumors, but women can also certainly have large tumors as well. So the differential diagnosis is to make sure that nothing else is going on as you're evaluating the patient. And certainly the most common cause of amenorrhea and hyperprolactinemia is pregnancy. And this shows the gradual rise in prolactin levels over the course of gestation in the normal individual. And this is due to the stimulation effect of the high estrogen levels from the placenta stimulating lactotroph hyperplasia in the normal individual. And prolactin levels can be quite high at term. There are a number of drugs that can interfere with the normal inhibition of prolactin by dopamine. The most common ones are the phenothiazines, the atypical antipsychotic agents, verapamil, metoclopramide, the Reglan given for diabetic gastroparesis, are common drugs to cause hyperprolactinemia. The antidepressants are very uncommon, and SSRIs are very uncommon causes of hyperprolactinemia. And then we turn to the pathologic causes of hyperprolactinemia. We're going to be focusing on prolactinomas, but realize that other things can interfere with the normal inhibition of prolactin by dopamine, and so that hypothalamic disorders, large pituitary adenomas that don't make hormones can interfere with the normal inhibition of prolactin. And then finally, hypothyroidism can do this. You can have stimulation of afferent pathways from the chest wall. Remember that in the normal woman who is breastfeeding after delivery, that breastfeeding will stimulate a certain rise in prolactin. So that stimulation of the nipple can cause a rise in prolactin, not just in pregnancy, but in non-pregnant women as well. Such things as nipple rings with irritation of the nipple can sometimes do this as well. So the standard therapy that we have for hyperprolactinemia is using dopamine agonists. So dopamine normally inhibits prolactin secretion, and so that we have drugs that stimulate that dopamine receptor, and these are bromocriptine and cabergoline. And they will normalize prolactin levels, and patients can get remission of the symptoms in over 90% of patients who take cabergoline, about 70 to 80% with bromocriptine. And so there are much less signs of adverse effects with cabergoline as well, so that it tends to be the preferred medication. It also can reduce tumor size, and in over 80% of those who take cabergoline, and about 60% with bromocriptine. And sometimes as you reduce the size of these tumors, you can then decompress the pituitary and restore normal pituitary function. And indeed, they control tumor size, and so that they can prevent progression of that tumor as well. So this is the kind of tumor size reduction that you can get. And I showed you the MRI of this patient before. And so this is the large tumor with cavernous sinus invasion, taking bromocriptine for several years. And now this patient has a partially empty cellar with a stalk coming down, and all of this tumor is essentially gone. Now, one of the concerns that has occurred with cabergoline is the risk of cardiac valve abnormalities. And this came out years ago for patients who have Parkinson's disease who take very large doses of cabergoline for Parkinson's. And you can sometimes get valve abnormalities of the mitral and tricuspid valve with valve regurgitation. And so the issue then came out, would we see the same thing in taking cabergoline for patients with prolactinomas? But the dose ranges are very different, because patients who take cabergoline for prolactinomas take about 3 to 5 milligrams a day, and for patients with prolactinomas, we usually give less than 2 milligrams per week. So a very different magnitude of treatment. So this is a survey that was done looking at among many different types of surveys, looking at the ratio of getting these valve abnormalities. For Parkinson's disease, the odds ratio was 4.58, and again, the dose of 4.1 milligrams per day, whereas for patients with hyperprolactinemia, there was no increased odds for development of valve abnormalities, but again, looked at the dose of 1.7 milligrams per week. So really a very different type of problem. On the other hand, sometimes we find resistant patients who need larger than usual doses, and in those patients, we will follow those with echocardiograms. So surgery certainly can be done for patients with prolactinomas. These are the data from the best of surgical series showing that you can normalize prolactin levels in about 80 to 90% of patients with microadenomas, somewhat less with the larger tumors, but there's a 10 to 20% recurrence rate. So this bottom line of 60 to 80% permanent normalization is sort of the figure that you would use for patients. So the indications that we would have for a patient to go to surgery would be a patient who doesn't tolerate the medication or who is not responding to the medication, for a visual field that doesn't change over a period of several weeks to the medication or one that worsens, for a tumor that grows while on medical therapy, and then very rarely patients will have apoplexy where they'll bleed into a tumor with a sudden increase in size, and many of those patients may need surgical decompression. And then finally, you can get CSF rhinorrhea. So if you picture a patient with a large tumor down at the base of their skull, and then you shrink that tumor, sort of serving like a cork, and you shrink the cork with a medication, you can then get leakage of CSF around the cork. And this, of course, opens up an open area where you can get meningitis, so that you have to repair that. The final issue of concern is in pregnancy. And I already indicated that the high estrogen levels from the placenta stimulate normal lactotroph growth, but they also can stimulate growth of a prolactin-secreting tumor. And so we worry about size changes that occur. There's also the concern that you really need to use the dopamine agonist to restore normal ovulatory cycles. And so the woman will be taking the medication to allow ovulation and pregnancy to occur. So you'll have exposure of the developing fetus for the first few weeks to that medication. And so that the question is about the safety of this. And so we now know that looking at patients who have been treated like this, so they've got exposure for 4 to 6 weeks, by the time somebody misses a period, realizes they might be pregnant, but there are no risks of multiple births, there are no risks of fetal loss or malformations occurring. The database for bromocriptine is about 5,000 or 6,000. That for cabergoline is just over 900. And so some people look at this difference in the database size and therefore prefer bromocriptine for pregnancy. I think that there's no suggestion, there's no even a hint of a smoking gun for cabergoline, so I don't have a problem with cabergoline in this regard either. So this shows the tumor enlargement that can occur during pregnancy. And this is a patient of mine who sort of had this borderline macroadenoma here prior to becoming pregnant. And then at about 8 months of gestation, she presented with increasing headaches, and you can see the increase in size of this tumor. And so the data are shown here for the increase in size of patients with microadenomas is a little over 2%. For macroadenomas, it's close to 23%. So clearly a difference because of the already propensity for growth of these macroadenomas. On the other hand, if you operate on a patient like this or irradiate them, you drop this risk down considerably. So what we tend to do with patients who want to become pregnant, if they have these small microadenomas or a very small macroadenoma, we just sort of establish intermenstrual interval. We stop the dopamine agonist when the period has been missed, and then follow the patient symptomatically every few months. And we then only will do visual fields or MRI if they start complaining of visual problems or increasing headaches. And MRI is important to do under those circumstances to document that a headache may actually be due to tumor expansion, since you may then intervene with medication, a dopamine agonist again, which usually works, or even surgery. There are no data to show that MRIs are harmful to the developing baby or to the mother during pregnancy. There's no data to show that gadolinium is harmful, yet it's very difficult to convince a neurosurgeon, a neuroradiologist to do an MRI. Now for the larger tumors, the ones that are very large, if a tumor has shrunk down very nicely and then the woman wishes to become pregnant, you're worried about sudden re-enlargement of that tumor that initially grew very slowly but now may be growing very rapidly when you stop the dopamine agonist. And so possibilities would be to debulk the tumor prior to surgery, prior to pregnancy, to stop the dopamine agonist once they're pregnant and just sort of follow them along, or even to continue the dopamine agonist throughout the pregnancy, although that's clearly not FDA approved for that. If the tumor does enlarge, we usually reinstitute the dopamine agonist. Surgery can be done if there's no response to the dopamine agonist. Or if the patient is, at 37, 38 weeks, it may be prudent to do delivery of the baby and the placenta at that point, rather than do one of these interventions. Okay, well, I'm going to change course a little bit here and talk about acromegaly. And this is a patient of mine who was a school teacher. She was also an advisor to the high school yearbook. And so she had a picture taken in exactly the same pose over the years. So you can see the gradual evolution of her features over the course of time. Of course, it would be nice to have intervened somewhere around here rather than here when her appearance changed considerably. So in general, we have a pituitary tumor for patients with acromegaly that makes growth hormone. The growth hormone then stimulates IGF-1 from the liver and a variety of other tissues, and the combination then stimulates growth of the various tissues that we usually talk about. So that there are a number of comorbidities that occur with acromegaly. There's hypertension, there can be cardiomyopathies, increased risk of strokes and headaches, hypogonadism occur. Arthritis is a major problem for patients because of the cartilage overgrowth that occurs within the joints, which then itself then causes further joint destruction. Glucose intolerance and diabetes is common. An increase in colon polyps and in colon cancer in some circumstances. And sleep apnea is also more common in patients with acromegaly. So survival overall is decreased in patients with acromegaly. This is not the case with prolactinoma patients. Survival is normal in patients with prolactinomas, but clearly it's decreased. And if you have complications, diabetes or cardiac disease, it impacts survival even more so. So when we diagnose patients with acromegaly, we need to show that growth hormone levels are elevated. that they are not suppressed as they would be normally with a glucose load, and also measure the IGF-1 levels, insulin-like growth factor 1, to show that that's elevated as well. Once we have biochemical proof, then we'll do an MRI scan, look at this tumor. And most of these are macroadenomas as opposed to the prolactinomas, which are usually microadenomas. Again, visual fields only if the tumor's abutting the chiasm, and also evaluate for hyperpituitarism. So what we like to do is to get growth hormone levels down to less than 1. And so that when we do so, we find that we can normalize the survival rate in these patients. So growth hormone less than 1 here compared to 2, 5, and greater than 5. Similarly, we can look at the IGF-1 score and look at this. Now, this is age adjusted, so we sort of go by standard deviation scores. And so that within 2 standard deviations, and then you really have a normalization of the survival rate compared to persistently elevated IGF-1 that's adjusted for age. Surgery is the mainstay for treatment of patients with growth hormone secreting tumors, unlike prolactinomas where you use medication. And that is because our medications for these other types of tumors aren't nearly as effective as dopamine agonists for prolactinomas. And here again, you can see cure rates in the 80 to 90% range for most tumors, with lower success rates for the larger tumors. Radiotherapy is also effective, but it takes a while to work. And so this looks at the effect of fractionated radiotherapy, the conventional dose given over 5 weeks, versus stereotactic radiotherapy. And you see here that after about 10 years, about 2/3 of patients can get normal levels with conventional radiotherapy, and after about 3 or 4 years with the stereotactic radiotherapy. So in general, we tend to go with the stereotactic radiotherapy when we want to do so. But if we're going to use that as a primary or even secondary treatment modality, you're obviously going to go many, many years with continued hormone elevation, which will cause the adverse effects of acromegaly. So you need to treat those patients medically. And the mainstay that we have for treatment of patients with acromegaly are somatostatin analogs. And for those of you who vaguely remember your physiology, somatostatin is the inhibitory factor that shuts down growth hormone secretion in the normal person. And so we have long-acting analogs of somatostatin that will decrease growth hormone levels and decrease IGF-1 levels. And these can normalize levels in about 40 to 50% of patients. Now, one interesting drug that we also have available for the treatment of acromegaly is a drug called pegvisomant, which is a growth hormone receptor antagonist. So normally, growth hormone receptor dimerizes, and so that in response to growth hormone attaching to that dimerized receptor, then changes the configuration to cause activation of that receptor. So with this antagonist, there's an increase in binding occurring to one site and a decrease in binding to the other site that prevents this bioactive dimerization from being effective. And so when you look at patients who are then treated with this medication, you can normalize the IGF-1 levels in almost 90% of patients. So this is a very effective therapy. It has to be given by daily injection, whereas those long-acting somatostatin analogs will be given on a monthly basis. And in fact, the two can be given together in combination. Well, now we'll turn to Cushing's. So this whirlwind tour of pituitary tumors. And we have to remember that there are multiple causes of Cushing's syndrome. And the one that we're going to focus on is Cushing's disease, which is a pituitary tumor making ACTH to stimulate the adrenals to make cortisol and to cause hypercortisolism. You can have ectopic ACTH secretion from lung cancers and other types of tumors. And of course, you can have primary adrenal tumors that can be benign or malignant, making cortisol, but under these circumstances, ACTH levels are low. So the problem for us as clinicians, as we're evaluating patients, is to identify the source of the abnormality. And so we first distinguish between an adrenal tumor versus ectopic-mediated tissue, and then we have to sort out between the ectopic and pituitary sources of ACTH. So we confirm our initial clinical suspicion with that dexamethasone suppression test that you're familiar with. We can measure 24-hour urinary free cortisol. And then lately, we've been turning to looking at salivary cortisols done at bedtime at midnight. And so if we find that there's a presence of Cushing's syndrome, then to differentiate between the causes, if there's ACTH elevated, we'll do an MRI of the Sellar. We may do a high-dose dexamethasone suppression test, and then petrosal sinus sampling, and I'll show you that in a moment. If the ACTH levels are low, then you go directly to imaging the adrenal gland, and then if the results are equivocal with both sides, you might do adrenal vein sampling. So this issue about doing late-night salivary cortisol really takes advantage of the issue that in all types of Cushing's syndrome, there's a loss of a normal diurnal variation. So remember, we normally will measure cortisol at 8 o'clock in the morning, and that's because that's when the levels are highest, as seen here. And then you have low levels as the cortisol levels gradually decrease through the course of the day. But when you have autonomous secretion of either ACTH or cortisol, you start to lose this diurnal variation in the mild case here and then in the severe case, so that at midnight you have persistently elevated cortisol levels in the blood. Well, it's not so easy to get a blood cortisol level in the person without hospitalizing them, but you can measure cortisol in the saliva, which is a very good indicator of what cortisols are. And so this is a summary of series that have looked at the sensitivity and specificity of doing these late-night salivary cortisols. And you can see there's really excellent type of sensitivity and specificity. So we really have moved to doing these salivary cortisols at night as a very early test for initially diagnosing and then confirming Cushing's syndrome. Now let's come back to this issue of inferior petrosal sinus sampling. It sounds pretty awful, and actually is a pretty major procedure. And so what happens here is that catheters are threaded up through the groin into the jugular vein on either side, and the petrosal sinus is really the sinus here that's sort of getting blood that's coming right out of the pituitary gland. And so therefore you can sample the immediate effluent of blood into the veins for ACTH levels on either side and get an idea of what the ACTH levels are centrally compared to what they might be peripherally. And so this helps you determine whether ACTH is coming from the pituitary or from some ectopic source where the levels will be the same in all of those. And so if you have an increased ratio in this petrosal sinus blood compared to peripheral blood of greater than 2, we can also give corticotropin-releasing hormone, which just amplifies that difference, as shown here. But you can have a false positive diagnosis if somebody doesn't have Cushing's. So in any of you in this room, if we did this test and you don't have Cushing's, presumably, you would have most of your ACTH coming from your pituitary, so you can get a false positive test. So you have to establish the diagnosis of Cushing's syndrome to begin with, and that it's ACTH mediated before you go to this. This is only to differentiate between pituitary and ectopic ACTH secretion. Well, we operate on most of these patients, and the cure rates are really quite good. Again, 80 to 90% for microadenomas, and less so for macroadenomas. The recurrence rate's about 9 to 10%, and mortality rate is finite. These are very sick patients sometimes. Now we have a number of medications that now have become available, some of them in recent years, and they can be directed at a number of sites to treat Cushing's disease. And so we have cabergoline, which is a dopamine agonist that we talked about for prolactinomas, that can decrease ACTH secretion. Pasireotide is a new somatostatin analog that also decreases ACTH secretion. There are a number of drugs that are used to decrease the synthesis of cortisol in the adrenals, including ketoconazole, mitotane, etirapone, etomidate. And then finally, we have a new drug that acts on the glucocorticoid receptor called mifepristone that blocks the action of hydrocortisone on peripheral tissues. And so some of these drugs are old that I'm not going to go through this with you, and I'd like to sort of just focus on the two new drugs that are available. Cabergoline is actually an old drug, but it's newly been used for Cushing's. And it shows here from these data that about maybe a third of patients or so can respond to cabergoline for Cushing's disease. And so since cabergoline is easy, it's relatively cheap compared to the other drugs, it's always worth a try, although it's not that successful, but it's relatively simple to use. Now, mifepristone, some of you may remember, this is RU486. So this is a progesterone receptor blocker, an old abortifacient, which has been around for a long time. So it turns out that it also blocks the glucocorticoid receptor, and so that when you treat patients with Cushing's disease and Cushing's syndrome of all sorts, you can improve the manifestations by blocking that glucocorticoid receptor. So here we see the improvement in glucose tolerance in people getting glucose tolerance tests as recently as early as 6 weeks. One of the problems here with this the glucocorticoid receptor blocker, however, is that you're blocking the biochemical effects, but you're not blocking the hormones themselves. And so the hormone levels actually increase. And so here you see the rise that occurs with the urinary free cortisol shown in green, the salivary cortisol in red, and even ACTH levels in these patients who have Cushing's disease. And so that you're blocking the biological activity, but not the hormones themselves, so that to treat patients, we really have to rely upon clinical symptoms of patients in judging the dose of patients of the medication, and that may be difficult. There may be adverse effects from this medication. When you have these higher levels of cortisol, they have bioactivity at the mineralocorticoid receptor and activate that receptor, and so that this can cause edema, hypokalemia, and this can be treated with a spironolactone or a eplerenone, which is a mineralocorticoid receptor blocker. Endometrial hyperplasia can occur from this anti-progesterone effect, and menorrhagia can occur. This is not a pre-malignant type of endometrial hyperplasia. It's sort of a separate type of thing, but nonetheless can cause problems with the menorrhagia. And then finally, adrenal insufficiency can occur because you're blocking the action at the receptor. And if somebody does develop clinical adrenal insufficiency, remember, we block that receptor, so you have to give a huge dose of dexamethasone to overcome that blockade, such as 10 milligrams of dex, which is a pretty large dose. Pasireotide was the other new one that has come out in the last couple of years. And here we see the effects of it in lowering elevated urinary free cortisol levels, UFC, to normal. And so patients who have very mild elevations of urinary free cortisol in the 1.5 to 2-fold elevation, about 31% can get normalization of the urinary free cortisol. With higher levels, you have a lower rate of success with using this medication. And this has now been approved by FDA and is available for treatment of patients with Cushing's. There can be some adverse effects, just like we see with any type of somatostatin analog. We can see some GI type of side effects, which are really pretty common. But you may also, if you overtreat the patients, you may then get hypocortisolism, but then you just adjust the dose of the medication. The major adverse effect, however, is hyperglycemia. Remember, we just saw with mifepristone, you get hypoglycemia, or at least a reduction in glucose levels. Here you see an increase in glucose levels. So you're reducing ACTH, you're reducing cortisol, but all somatostatin analogs will also reduce insulin secretion, and this drug in particular also reduces GLP-1, glucagon-like peptide 1, and glucose insulinotropic peptide, GIP, both of which facilitate insulin secretion. And so this causes the hyperglycemic effect from this medication as an adverse effect. Now, other tumors, the TSH-secreting tumors, much less common. So that here we normally have a patient who's got Graves' disease with standard hyperthyroidism, elevated T4 and T3 levels, and it suppresses the TSH. In this circumstance, you have a tumor making TSH, causing the hyperthyroidism. So if you see a hyperthyroid patient where you don't have a suppressed TSH level, you should start to think of a TSH-secreting tumor as the cause. Surgery is generally the treatment. And then again, one thing that we learned back from basic physiology is that somatostatin inhibits TSH secretion as well as growth hormone. So the somatostatin analogs like creatide and lanreotide are also very successful at treating the TSH hypersecretion from these tumors. And so you can reduce TSH levels, you can normalize T4 and T3 levels in over 90% of patients. And so this is a good medical therapy for the patient who's not cured by surgery. Let's turn now to the last category, and these are patients who have clinically non-functioning pituitary adenomas. And so these are tumors that present because of mass effects, or they're found as incidental things on MRI scan, asymptomatic tumors. So these are not tumors that make a clinical syndrome due to hormonal oversecretion. So one of the issues then is the asymptomatic tumor. So the patient, you're doing MRI for dizziness or some other complaint from the patient, and you find an incidental pituitary tumor. Well, this shouldn't really be a surprise, because if you look at autopsy series of pituitary tissue that's examined, you find here that there's over 18,000 pituitaries looked at in these series, and about 10% of normal people have pituitary adenomas. And if you then stain those, about 40% stain for prolactin. So there's about 50 people in the room here. So 10% of you have pituitary tumors, statistically, and at least 2 of you have prolactinomas, so just think about that. Okay. So what do we do with these? So you may have hormone oversecretion from these incidental tumors that may not, they may be early on in their development, may not have a lot of clinical manifestations. So we'll do an IGF-1 test. Now we're doing late night salivary cortisol levels, basal prolactin level in a patient like this to look for the patient with perhaps early secretion of these hormones. It's probably not worth doing FSH and LH and TSH levels because they can be very confusing for the gonadotropins, for menstrual cycle, et cetera. And TSH secreting tumors are really pretty uncommon anyway. So then if you find these asymptomatic tumors, what do you do with them, these incidentalomas? Well, we actually have data from the literature as to looking at what happens to these over the course of time. So if you have a patient with a microadenoma that's found and follow them over time with serial MRI scans, you find an 11% increase in size, 6% actually decrease in size, and over 80% just don't change. They just kind of sit there, don't seem to do very much. On the other hand, the macroadenomas, 24% of these enlarge over time. So these have already indicated some propensity for growth at the time that you're initially evaluating them, so it shouldn't be a surprise that more of them might grow, but 13% will actually decrease, and 63% really had no change. And some of these macroadenomas that grew because there was some bleeding into the tumor that caused enlargement of that tumor. So that sort of guides you with that kind of data as to what to do with these patients when you see them. So the first thing is that we evaluate pituitary function. If they are hyperfunctioning, we're going to treat them like all of the other patients that we've already talked about with the various types of secreting pituitary adenomas. But then the issue is that they are non-functioning type of a tumor. So if they're a microadenoma, less than a centimeter, we're not terribly worried about them. Repeat the MRI scan at perhaps 1, 2, and 5 years, looking for that small percent that's going to continue to grow. And if you have evidence of tumor growth, then you may well operate and remove those tumors. If you have a larger tumor, then you're more concerned about growth of these tumors. Clearly, the tumor that's abutting the chiasm, you do visual field testing. If the visual fields are abnormal, then this would be an indication for surgery. You would look at pituitary hypofunction. And so if you find hypopituitarism, that in and of itself could be an indication for surgery. But again, we're going to repeat the MRI in these patients. If you find no growth, then you can continue to follow them. If you do find growth, then you may want to operate on those patients. How much growth would be an indication for surgery is obviously individualized for the patient with risks and benefits and also the experience of the neurosurgeon. When you stop doing MRIs, nobody really knows, but there's data to suggest that some tumors may take years before they show evidence of growth, so up to 10 years or more. So nobody knows exactly how long to keep doing these MRIs. So the symptomatic patient, and this is sort of the last group we'll just talk about for a moment, they present with all of these types of symptoms. Visual field defects, hypopituitarism, headaches, ophthalmoplegias are less common from that invasion of the cavernous sinus, pituitary apoplexy from hemorrhagic infarction of these tumors. So there can be a variety of ways in which these tumors will present. So we treat the hypopituitarism, and it's relatively easy for us as endocrinologists to treat that. We'll treat them with glucocorticoid replacement, as you see here, hydrocortisone. These are patients who are lacking ACTH. They're not having total adrenal wipeout, so they don't need mineralocorticoid replacement. Thyroxine, and monitor with 3T4. Do not measure TSH levels in a hypopituitary patient. Doesn't really help you very much, so we just monitor with T4 levels. And then give estrogen or testosterone replacement to individuals as necessary. Now, if fertility is an issue, then that becomes much more complicated in a hypopituitary patient, and really you may need to give gonadotropins for a patient like that. It's a lot more involved. And then finally, growth hormone. And so growth hormone, giving it to kids, obviously, that's a normal thing to do to have them grow. But in adults, it also seems to have some improvement in muscle mass and strength, decreases in body fat, improves the quality of life in many patients. There's some growing evidence that perhaps it has improvement in cardiovascular outcomes as well, but that's really much more shaky. And so if you have these large tumors and you have the patients who are hypopituitary, then you operate on the patient, and in fact, sometimes the pituitary function will improve. And so here we see restoration of normal LH and FSH in 22%, and ACTH and TSH in over 40%, and there may be hyperprolactinemia from that lack of dopamine getting down, that also improves and 3/4 of those patients. So that this may be a relative indication for surgery as well. Well, I'd like to thank you for your attention. I'll be happy to answer any questions. Or not.
Mark, thank you for that tour. That was wonderful. I have a question about the use of dopamine agonists and prolactinomas. You know, in the past, this was a lifelong therapy, or at least considered lifelong therapy, and now there's some data that certain individuals may be able to, you could trial off the dopamine agonist. I was just wondering what your approach is.
Yeah, that certainly can be done. It doesn't have to be lifelong, and perhaps somewhere between 20-30% of patients can be tapered down to a low dose and then eventually tapered off medication. And people who've got normal levels for a couple of years will often try to taper them down and eventually off. In fact, somatostatin analogs can sometimes be tapered off in patients with acromegaly as well. Brad?
Yeah, you gave data on surgical success in these various tumors, but that's largely dependent on the experience and expertise of the surgeon. And we happen to have a terrific surgeon here at the University of Washington, but my question for you is, how are clinicians in the audience, as they scatter throughout the United States and do their practices in the future, how do they get meaningful data on how successful their local surgeon is? Because you'd want to refer a patient somewhere else if you don't have a terrific surgeon. And it's not just experience. You can be experienced and ineffective.
Right. Right. I think that's absolutely correct. And in fact, you saw our neurosurgeon, so we don't actually send patients to our own neurosurgeon. And we send them elsewhere to other institutions. Doesn't get me any favors at my own institution, but I'm not going to send my patient to a surgeon who doesn't have a high cure rate for patients. So you need to ask your neurosurgeon for their data. They should be able to provide you that data. We as endocrinologists are really the ones who keep them honest, because we look at the hormone values after surgery and we know which patients are cured and which patients aren't cured. When you talk to the surgeon, when they come out of the operating room, they said, oh, we got it all out. That patient's cured, no problem. But in fact, we look at that data and we can tell which patients are cured and which patients aren't. So you got to look at your data and the data from your own neurosurgeon, and if it's not approaching these numbers that we talked about, send the patient elsewhere for their surgery.
My question is about treatment of hypopituitarism causing adrenal insufficiency. You also mentioned using hydrocortisone. How often do you use prednisone? Because in my mind, you don't need the mineralocorticoid activity, as you mentioned, but just prednisone is much easier dosing rather than hydrocortisone. So how often do you use that?
Right, so the question is about using prednisone versus hydrocortisone. That certainly is appropriate to use. It depends on the patient. Prednisone is far cheaper than hydrocortisone and certainly can be used. You'll find some endocrinologists are very opinionated to say, oh, hydrocortisone is the normal cortisone, we should use that and not prednisone, and I think that's kind of nonsense. I think using prednisone is fine. Any comment? Yes, I think.
You know, our classical teaching is that after you have treatment, including obviously the stereotactic treatment, that you need to watch for hypopituitarism. And yet we have, when you follow people out oftentimes 15, 20 years, and they've clearly had hypopituitarism documented, no question, and yet they'll stop taking their medication. And then it's like, well, how does this happen? It's normalized. Can you comment on that? Because the literature on that is really quite vague.
Yeah, it's sort of surprising patients who have pan-hypopituitarism and they stop their medication. I've seen several patients like this, then they don't come back either. Then a year later they show up. I haven't been taking any of my medication for a year. You measure the hormone levels, their morning cortisol is 1, their free T4 is 0.1, and you ask them how they feel. Then, oh, I'm a little tired. It's sort of surprising how well they do when they look like they're dead on paper. I'm always astonished. I don't let them continue that way, however, and I'd be very concerned if that patient fell off a ladder or broke their leg, and if they couldn't raise their cortisol in response to a stress like that, what might happen to somebody like that? Any comments? All right. Well, again, thank you very much.